and I realized when preparing that I never have visited Israel, which is really a shame. And so I always heard from colleagues who attended conferences in Israel that it is such a beautiful country. So too bad, but there might be other occasions. So I will talk. Well, let me first give you a brief note where I'm based. As you can, I hope you can see my mouse. The University of Leuven is located about 30 kilometers of Brussels, and I'm currently sitting somewhere here at the point of my cursor. This is where I live, and it's in amidst of the cows and the prairies and so on. It's a very quiet location here. Leuven itself is a really is an old university town, small university town with a big university, about 60,000 students on a population of somewhat like 110,000 inhabitants. So it's really dominated by the university, and it's an old medieval town. Our research group, which I built up together with other people in the last 15, 20 years, is basically focusing on the psychology of aversive somatic experiences. We look at pain, we look at dyspnea or breathlessness, and recently also into gastro-related pain. And we mostly develop lab studies using healthy subjects and we inflict pain, we inflict dyspnea to them, and then we measure these different levels of responses like self-reported psychophysiology, behavior responses, and brain responses. And then we also do translational studies and occasionally also clinical studies focusing on chronic pain and respiratory disorders. This is like, in a nutshell, what we are doing. So what is the content of my talk? I will give you a very brief introduction in respiration and in the psychology of breathing regulation. And then I will talk a bit about COVID-19 and breathlessness, and then discuss a number of examples of how breathing distress can act as a source of learning, which has impact on many different diseases and health problems, and which I presume that also it impacts a lot on COVID-19. But we do have very little data on this disease yet from the psychophysiological perspective. So these examples are mainly exemplars, as I would say, and I hope that they can inspire research on COVID-19. And then I will also briefly conclude with breathing as a sort of treatment. So why respiration? You probably are aware that respiration is the biggest oscillator in the body, and it's closely coupled to cardiac activity. So cardiorespiratory activity is very closely coupled, but breathing is dominant upon cardiac activity. It's critical for moment-to-moment survival, and breathlessness is therefore also extremely panicogenic. And it is also deeply involved in autonomic regulation. You probably notice here the Bridge of Sighs in Venice, and I will talk about sighing also later. Breathing is intricately connected to cognitive load, sustained attention, working memory, emotion and stress like panic, fear, passion, love, despair, and pain. And breathing is also deeply related to relaxation and autogenic training, yoga, meditation, mindfulness. So interestingly, compared to what I consider its relevance, It is rather poorly investigated in the scientific literature, and it seems to attract much more esoteric rather than scientific literature. Why is it so little investigated in psychophysiology despite its importance? Well, psychologists turn to psychophysiology because actually they want to circumvent reliance on self-report. So looking at looking at bodily responses was very interesting for psychologists because they were not influenced by voluntary processes. Now, breathing, respiration is double controlled. That means it is both voluntarily and autonomically controlled. And so in that respect, it was no pure psychophysiological measure because you could influence it voluntarily, just like self-report. So it has always been a bit suspect. And an additional problem is that it is difficult to measure it, especially volume, without altering it. So this is why breathing is somewhat less investigated. Well, I would say largely less investigated compared to cardiac activity in relation to mental processes. Okay, why do we breathe? This is very basic, but you know that we breathe to keep blood gas levels within preset boundaries. Arterial pressure of CO2 and arterial pressure of O2 is of paramount importance for our survival. Also, it's very important to keep our acid base within preset boundaries. And it might be good for you to know that CO2 regulation is more narrow and more compelling than O2 regulation. That means we can stand better this regulation of O2 than CO2, although only within boundaries. This is a classic CO2 feedback system. If you would hyperventilate just a little bit and you would enter an hypocapnic state, this would increase blood pH level and decrease blood CO2 levels, which is a stimulus for respiratory centers in the sense that it decreases stimulation, which leads to decrease in respiratory activity and minute ventilation, which allows blood CO2 levels to increase and causing the blood pH to decrease. Hypercapnic state just do the opposite, and I will not go into detail, which is actually the reverse of what I just was saying. And this is, let's say, considered especially by medical people as the major regulation system of CO2. What I will in a moment try to tell you is that it is only part of the story. But let me just go into detail about some respiratory control mechanisms. There is peripheral and central chemoreceptors. There are stretch receptors, mechanoreceptors, and there are also proprioceptors in muscles and joints, receptors for and so on, that all contribute to input in the respiratory center, in the medulla and the pons, and these determine the rhythm of respiration to produce a balance between frequency and tidal volume, leading to minute ventilation. And minute ventilation is the amount of ventilation during a minute, and this is a very important parameter. You can measure it with a pneumotachograph, as you can see here, and you can also use respiratory band after calibration with a pneumotachograph to assess minute ventilation or the volume parameters. Frequency parameters are much more easy to register of yours. Very important to know is that there is no dyspnea receptor. It's not like you have pain receptors. There are no dyspnea receptors. And dyspnea results from a complex integration of different sources of information. Just to give you a brief idea how we induce breathlessness in the lab, here we use CO2 inhalation, which triggers the chemoreceptors and produces air hunger. Here we use flow resistors or loads. These are resistors put on the breathing system. These are mechanoreceptors and they produce sensation of effort. We also have regularly used occlusions, sudden occlusions of breathing, occlusions of the respiratory system, which results in a suffocation fear. An interesting thing I want to mention is that end-tidal CO2 can be easily measured with a capnograph, an ambulatory or a bedside capnograph here. End-tidal CO2 is the CO2 level that is reached at the end-tidal plateau during expiration here, as you can see here. And this is a very interesting parameter, as I will explain in a moment. So you have arterial, alveolar, and end-tidal CO2 that are all coupled. And you can also use these measurements, these capnographs, to use to measure pulse oximetry, which also an interesting measure you could easily use. Okay, just to give you an idea of some clinical relevance, this is a study showing that PCO2 levels predict poorer outcome from behavioral treatment. This is a study on 61 anxiety disorder patients of different types, 12 sessions of CBT or ACT, acceptance and commitment therapy. And this low baseline PCO2 predicts higher anxiety symptoms, lower quality of life across all follow-up time points and above and beyond baseline symptom severity. So there are plenty of those studies that show that end-tidal CO2 is really an interesting measure, but unfortunately it is overall not very frequently used. Okay, some brief words about the psychology of breathing regulation. As you can see here in this picture that I just showed you, there is also a lot of room for higher centers in the brain to control breathing and for emotional stimuli to act upon the limbic system, which impacts also on the breathing system. One simple example here is just showing affective pictures using the IAPS picture system that you might know impacts the inspiratory motor drive. So neutral pictures, positive pictures, threat-related and pain-related pictures, they almost induce a dose-response relationship between the affective quality of the pictures and the inspiratory motor drive. And this is just watching pictures without doing anything else. Another example I want to give about the importance of what happens in the brain for respiration. This is a systematic review of responses to cognitive load. And what you see here is that in terms of Cohen's d respiratory rate and also the CO2 output per unit of time is associated with the largest effect sizes in terms of impact of cognitive load on respiration. So respiration can actually very reasonably be used as a measure of cognitive load. Another interesting issue that I want to briefly mention breathing regulation is that these PCO2 levels, they don't show any oscillatory pattern most of the time. which is really strange. If you only have a feedback loop, if CO2 levels would only be regulated by feedback, then you would see a typical oscillatory pattern, because you always need an error that needs to be corrected. And that produces an oscillation pattern. So the question is PCO2 only feedback regulated? And there is plenty of evidence that it is not. Even two-day-old mice can learn to breed after just 2 acquisition trials. So the breeding system is very, very sensitive to learning mechanisms. And we also established that in humans. So basically the message of these studies is that breeding is mainly or largely determined by feed-forward regulation. That is, errors are corrected before they occur. And this leads me to maybe a boutade that I like, but the brain is basically a prediction machine rather than a response machine. And it contributes to physiological regulation mainly and importantly by means of prediction or anticipation. So to sum up this part, breeding regulation is in large part behavioral feed-forward regulation. It involves anticipatory error correction, which runs automatically and unconsciously. And metabolic feedback regulation only comes in when physiological boundaries are reached or crossed, and in new and unpredictable situations. But our breathing system needs a continuous interplay between metabolic feedback and behavioral feed-forward regulation. And very easily, breathing dysregulation occurs. 2 main examples. When do we see maladaptive regulation? We see maladaptive regulation when anticipation seems to be wrong, so we correct an error signal that does not come. And when feed-forward response produces a stimulus by attempts to avoid it. So, for example, breathlessness is an interesting example, as I will explain later, because it easily produces vicious circles. That means attempts to avoid breathlessness actually produce breathlessness. And that is really detrimental for physical and mental health. Okay, the example par excellence, as I call it here, of maladaptive feed-forward regulation is hyperventilation, which is breathing in excess of metabolic needs. It means that more CO2 is expired than the body is actually producing, which leads to hypocapnia, a decreased PCO2 level in the blood, and a respiratory alkalosis, which is related, which means an increased blood pH level. And it has substantial effect, and I assume that I don't have to explain this to you, but you see a large variety of symptoms. Most of them are PCO2 related, but there are also several symptoms like respiratory and general fatigue, general symptoms like fatigue, headache, that are much more related to mechanical aspects of overbreathing and not to the chemical consequences of overbreathing. Now, why is hyperventilation such an important example? Because it is an example that metabolic regulation is very easily overruled by behavioral regulation. If only metabolic feedback would play, then hypocapnia should induce a decrease in breathing and correct itself. And this is what happens during sleep most of the time. That is, if hypocapnia occurs, you get to see long apneas, which is a decrease in breathing, and it raises the capnic level again. But we see typically in hyperventilation that it typically gets worse. And this is an example of the impact of behavioral mechanisms overruling the feedback regulation. Now, an interesting question is, what drives regulation in a feed-forward manner? And I want to keep this very short, but years ago, we did a study in which we manipulated the valence of an emotional imagery and the arousal level. So we had relaxation scripts, depression scripts, fear scripts, and joy or desire scripts. And we had people imagining those scripts for 150 seconds while we measured their end-tidal CO2. And then we had the recovery phase. And this is what happens here. You see here that the fear scripts and the desire scripts actually are associated with a decrease in end-tidal CO2, and most for this particular fear script here. While a depressive script and a relaxation script are all associated with slight increases in CO2. And so this shows that valence is not critical, but arousal is. So we are not, our body is not so much, our breathing system is not so much responding to the emotional quality, but to the arousal level of emotional imagery. And this is a nice example where we ask panic patients to imagine breathlessness. And this is what happens with their end-tidal CO2 level. So we use the same paradigm as the one before, 150 seconds of imagery. And in this case, we asked them to imagine breathlessness being in an elevator. Just thinking about it leads their end-tidal CO2 decreasing until below 30 of millimeter mercury, which is really into a clinical level, producing substantial symptoms. So just playing around with thoughts can already have an impact, a substantial impact on end-tidal CO2. So to summarize a bit on dysfunctional breathing, there is a lot of dysfunctional breathing, which is mostly emotion or stress related and most straightforward coupled to the arousal aspect. It is characterized by too rapid or too deep or too erratic breathing. It includes occasional hyperventilation, frequent sighs, and occasionally also hyperinflation. That means people are using a thoracic breathing pattern, which leads to hyperinflation and shortness of breath. It characterized at least 10% of the population, somewhat higher in women. And in my view, it is only the tip of the iceberg because it is most of the time not even recognized. So in my view, dysfunctional breathing is an important source of symptoms in daily life with pressure on the chest, several other vague symptoms related to hyperventilation and with substantial impairment of quality of life. And obviously it is moderated by personality and individual differences like negative affectivity, anxiety, sensitivity, perfectionism, and so on. What I will further discuss is that breathing distress or dysfunctional breathing can also be an important source of learning. But let us first turn to COVID-19. I have to say I'm not a COVID-19 expert, so I will only briefly go over some of the physiological aspects. So what you typically see initially is a severe hypercoagulation resulting from the virus propagation, impacting the diffusion exchange area. You see a lot of pulmonary edema with a reduction of the diffusion capacity for carbon monoxide and acute hypoxemia. That is at the same time a little hypocapnic and sometimes, or very often, eucapnic, which has some people led to coin the term happy hypoxia, because people are severely hypoxic without having the bad side effects of hypocapnia. So, and they feel actually little breathlessness from it. To the symptoms, and especially to the issue of breathlessness, because this is at the moment quite poorly understood. It is not due to acute hypoxemia or hypoxia, but basically experts do not really know for sure what might cause breathlessness, because in some people you have this happy hypoxia phenomenon. So some people are thinking that it is related to pulmonary edema and associated emboli, but it might also be related to interoception and impacted neurocontrol centers, affecting awareness of breathing, or affect-related mechanisms. We know that they are playing a role in breathlessness. So, and we also know that dyspnea may persist when hypoxemia has resolved. But what is for sure, that is, for many patients, COVID-19 is a disruptive emotional experience with shortness of breath and fear of dying. And recently, there is also substantial interest in what is so-called long COVID or post-acute COVID-19 syndrome. Just to briefly describe it, it is the label long COVID is used when post-infection longer than 12 weeks, there are still substantial symptoms, and they may persist for 1 year or longer. And it seems to impact at least 10% of the post-acute COVID-19 people. Symptoms are wide. The symptom range is rather wide: fatigue, dyspnea, cognitive abnormalities, as you can read here. Interestingly, it's very variable among and within individuals, and even within individuals, there is an irregular pattern. Some call it a corona coaster. And relapses are often triggered in response to specific triggers like physical or mental activity, stress, and so on. If you look at risk factors, then an interesting pattern emerges. So age and comorbidities, the typical risk factors for acute COVID, do not apply for long COVID. Severity of acute COVID is not critical because probability is not higher if you have been hospitalized or not. And it also occurs among individuals with mild COVID-19, which is the majority of the patients. It is predicted by the number of symptoms during the first week of illness. It is predicted by dyspnea at diagnosis, and it is also predicted by female sex, while men are more at risk for severe acute COVID-19. So more at risk for long-term impairment, fatigue, and anxiety, and they are also more at risk when there is a pre-existing diagnosis of depression or anxiety. So this makes this diagnosis a quite challenging one to understand, and we basically don't know what are the main pathogenic drivers. A very interesting study that just appeared recently in a population-based French cohort study comprising 35,000 participants. Their conclusion, which appeared in JAMA recently, was that persistent physical symptoms after COVID-19 infection are more associated with the belief of having been infected than with having laboratory confirmed COVID-19 infection. So these are all quite intriguing and challenging interpretations. So how can we try to understand these kind of findings given what has been said so far? I would like to discuss now a number of mechanisms that might contribute to dysregulation and long-term or persistent symptoms. And these are all based on learning mechanisms. And I would like to discuss briefly 3 types of learning as a result of breathing dysregulation or as a result of dyspnea or breathlessness. The first is called interoceptive fear conditioning, also learning to sigh, learning, and then learning of symptoms, learning to experience symptoms. Okay, the first, interoceptive fear conditioning. Many disorders are characterized by fear of bodily sensations like panic disorder, irritable bowel, pain, lung disease patients. And breathing distress, can it act as a source of learning in COVID-19? We actually don't know yet, but we know from asthma that asthma can be understood in part as resulting or influenced at least by an interoceptive fear learning. How can you think of this? Well, strong dyspnea or pronounced difficulty of breathing, which is associated with suffocating feeling and fear, is usually predicted by slight dyspnea. You don't get it all of a sudden. You get first slight dyspnea, then moderate dyspnea, and then you get this full-blown attack. And you can, if you look at it from a learning perspective, a classical conditioning perspective, and I assume I don't have to explain the Pavlov's dog here to this audience, but if you consider the strong dyspnea as an unconditioned stimulus and the slight dyspnea as a conditioned stimulus announcing the strong sensation of dyspnea, then you can look at what the impact is of slight dyspnea on fear learning, but also on respiration. And this is what we have been investigating in a couple of paradigms. And this is mostly work by my former postdoc and PhD student Ilse van Dist, who is now a colleague. And there are 2 types of paradigms that she investigated. One is called a heteroreflexive paradigm. That is, a flow resistor predicts a breathing occlusion. So you breathe into a breathing system, you feel a resistance, and a few moments later, you all of a sudden have a breathing occlusion. Why is it called heteroreflexive? That is because the response system here is different from the response system here. This is more related to chemoreceptors, and this is more related to mechanoreceptors. The homoreflexive paradigm is actually, you use a small a resistor of 10 millimeter mercury per centimeter water as a predictor of a strong resistor. And you have to imagine these learning paradigms as if people are having breathing trials characterized by a slight resistance followed by a strong resistor. And then different fear measures are collected. Some fear measures tap into the explicit memory system. Other fear measures tap into the implicit memory system, like startle potentiation, electrodermal response. Explicit memory system is self-reports of US expectancy. And this is a summary of many different studies that have been guided by my colleague Ilse van Dist. And what you see here is that startle learning occurs in both paradigms, respiration changes occur in both paradigms, but the explicit memory measures are not responding in the homoreflexive paradigm, but they do in the heteroreflexive paradigm. We replicated that a couple of times. So this is actually an interesting finding because it tells that we can learn to change our breathing without even knowing, based on this kind of experiences. I hope this is still clear enough for you. And this, you can imagine that this easily leads to vicious circle effects. Because we know that breathlessness, when you induce it in persons with high anxiety or high anxiety sensitivity, high fear of suffocation, it changes breathing in that it leads to stronger breathing against the resistance. And this exactly increases breathlessness sensations, which further increases fear of suffocation. Here you see some findings here of a German study that exactly show that. So, to put it very simply, repeated experiences of breathlessness changes your breathing in such a way that it contributes to more breathlessness. Can you imagine that this is really can be a detrimental experience? Probably it relates to some recent observations that gradually pop up more and more. We see that there is a high incidence of hyperventilation after COVID-19. Hyperventilation might be a possible explanation for long-lasting exercise intolerance and so on. So there is more and more evidence emerging that hyperventilation might be a consequence, a learned consequence of COVID-19. How it contributes to long COVID, we don't really know. But what we do know is that breathlessness and anxiety, or panic and depression, they have a bidirectional relationship in longitudinal prognostic studies. Asthma patients have 4 to 5 times more likely to develop panic disorder on the long term. And anxiety mood disorders plus asthma, they report 6 times more likely breathlessness. So all these findings suggest an intricate relationship between breathlessness experiences, mental disorders, hyperventilation, probability, and so on. And we also see now there is also emerging evidence that COVID-19 produces an increased risk for the development of mental disorders, both among non-hospitalized and hospitalized, but a little more among the latter. The risk is much higher compared to people with seasonal influenza, and the risk is much higher than for patients hospitalized for any other cause. So there might be an interesting, an intricate relationship between those two. Let me next go to another learning mechanism, and that is related to sighing. Actually, another postdoc now, colleague in Amsterdam, Elke Vlemings, did a PhD on trying to understand why do we actually sigh. Nobody really asked this question. From a physiological point of view, findings suggest that we reset our respiratory system when there is too little or too much variability. Then sighs are considered like a resetter. And this goes hand in hand with psychological effects. It produces psychologically relief. And we know from studies that Alpha-Flemings did that sighs express relief, but sighs also induce feelings of relief. And it produces relief as an emotional experience, but particularly when there is dyspnea or breathlessness at play, it produces relief of dyspnea. And this makes it really interesting, because if relief acts as a reinforcer of sighing when breathing distress is experienced or when dyspnea is experienced, then it might increase the sigh rate. And this is exactly what Bergh was able to show, that sighs can become learned behaviors through operant conditions. And this sigh might produce relief on the short term, so it produces a short-term benefit, but it might cause a long-term problem, because frequent sighing keeps end-tidal CO2 low, and we already know that from the panic literature. For example, these are panic patients, and this is the sigh frequency of patients with panic disorder, and this is their end-tidal CO2 level. And you see that overall they sigh more, overall their end-tidal CO2 is much lower, but whenever there are episodes with a sigh, it further decreases the end-tidal CO2. So frequent sighing keeps end-tidal CO2 low. So in some, breathlessness and breathing discomfort may contribute to increased breathing. That means increased minute ventilation, increased sighing, increased breathing instability and hyperventilation, and increased fear for breathing distress. So you can imagine that vicious circle are easily established here. Now, let me focus on a third learning mechanism. That will be the last I will discuss with you. But this is actually also a summary of a large number of studies that we did, in which we induced breathlessness and other symptoms, either through hypercapnia, CO2-enriched air inhalation, or through instructed hyperventilation, which causes hypocapnia. And we both consider this as an unconditioned stimulus or as an unconditioned bad experience. And then we had people going through repeated trials of hypercapnia in some paradigms or hypocapnia in other paradigms in association with predictive cues. For example, we added harmless odors to the breathing air, or we asked participants to develop certain imagery or to think about certain issues. And then we presented the cues alone, either the odors alone, or we asked them to imagine some scenes, and we looked at the effects on symptom reporting. Again, you can recognize here a Pavlovian conditioning paradigm. So this is happening when we induce a hypercapnic state through CO2 inhalation. We add CO2 from the bottle into the breathing system. Here is the subject, and we measure with a capnograph the end-tidal CO2, and we add some harmless odors to the breathing system. So what is happening? The subject experiences faster breathing, smothering sensations, all these symptoms. And this experience is mixed with odor cues, with harmless odor cues. And then after a couple of experiences, we present the odors only. And here you can see what happens in one of the many studies we did with this paradigm. This is ammonia as an odor and myaoli as an odor. I'm not going to explain in detail the design of this paradigm, but let me simply conclude from this study that people start to experience symptoms as if they are still receiving CO2, even if there is no CO2 anymore present. And this happens only when the odor has an unpleasant quality, which is really interesting. So it happens only with ammonia as a CS+, and it does not happen with niaouli as a CS+. Niaouli is an eucalyptic oil, a volatile oil, which has a fresh smelling odor. And you know this probably from Vicks, which is used by some people to have a fresh smell or to open up a stuffed nose. So this is what we repeatedly found, that presenting the conditioned odor only induces symptom experiences, but only when the odor is unpleasant. And we also could establish that people who are high on trait negative affectivity, that means people who are very threat sensitive, and clinical psychosomatic patients here, these are actually the best learners of so-called medically unexplained symptoms, symptoms unrelated to physiological dysfunction. We also looked at hypocapnia as an unconditioned stimulus. So we had people going through repeated hypocapnic hyperventilation trials, and we looked mainly at lightheadedness. We added odors to the inspired air during hyperventilation, and we used normocapnic hyperventilation as control conditions, and then we presented the odors only. And the result was that people report more lightheadedness in response to CS+ odors, although there is no hypocapnia anymore involved. And we also checked that by measuring cerebral blood flow and the correlation with the sensation of brain fog. So here, this is another collaborator of mine, in which we applied transcranial Doppler ultrasonography. And this is an example. Here, we have people going through an hyperventilation episode, which decreases end-tidal CO2. It also decreases cerebral blood flow substantially, as you can see here, and it increases lightheadedness or brain fog. This is what happens if you make a scan of the brain during hyperventilation. So it's pretty impressive, this impact of hyperventilation on the brain, and it is strongly correlated with this brain fog. For example, in our study, during the learning phase, when there was actual hyperventilation, lightheadedness correlated 0.64, minus 0.64 with cerebral blood flow. But then after repeated trials, we presented the odors only, and then people started to report lightheadedness or brain fog, which was completely unrelated to cerebral blood flow anymore. So this means that repeated symptom episodes actually create an uncoupling of the symptoms from the physiology. And that's really an interesting finding, I believe. So in sum, for this third mechanism, learned symptoms easily emerge after repeated breathing distress. It produces strong nocebo effects, and that means symptoms uncoupled from physiological dysfunction in response to associated cues, especially when they are negatively valent. And this happens more so in people, healthy people with high trait negative affect and with elevated symptoms in daily life. I cannot go into details about all the studies, but also in patients with psychosomatic traits. So this actually puts to the foreground the question, how can we perceive bodily sensations that are not really there? And this is obviously the same problem as for nocebo, placebo, medically unexplained symptoms. And I'm not going to explain the model that we recently described to explain how we can perceive bodily symptoms unrelated to the physiology. This model describes the conditions under which we have a strong correlation between bodily symptoms and physiological dysfunction, and when these when this connection becomes loose and eventually completely uncoupled. Okay, now just a final word about mindfulness, relaxation, and breathing. Many treatments have a focus on breathing, like mindfulness exercises, mindful breathing. I just copy here a couple of instructions. The exercise is simply to identify the in-breath as an in-breath and so on. So the object of your mindfulness is your breath, and you just focus your attention on it. Another example is focus on mindful breathing in mindfulness trainings and so on. So there are plenty of examples where focus on breathing is a big part of the treatment. And after having studied breathing in response to let's say psychology, or in relation to psychology, it's still a mystery. Why should we focus on breathing? I don't understand it. What we know from the lab, so why should you focus on your breathing and not on your left toe, for example? What we know from all of our lab studies is focus of attention on breathing interferes with accurate breathing regulation. One of the sayings in our lab is, if you want to disrupt accurate breathing regulation, focus on it. This is what we typically find. Another finding is a healthy breathing pattern is highly variable, and it's not at all regular and stable. So don't try to induce a stable, regular breathing pattern, would be my advice. But this seems to be opposite to what is used in clinical practice. But what we do know is that breathing is highly connected to autonomic regulation. So if it is a gate to autonomic balance, then my suggestion would be to use it. Now, what does that imply? Well, there is very interesting literature which shows that the respiratory rhythm acts as a gating mechanism. During inspiration, you have less vagal outflow and the heart accelerates. During expiration, there is more vagal outflow and the heart decelerates. And you all are familiar with the respiratory sinus arrhythmia and heart rate variability as an index of vagal parasympathetic activity. So I'm not telling you news on that. And we also know that heart rate variability, or RSA, correlates with stress, depression, and so on. So it's in general an index of good psychological and physiological health. Now, if you want to use respiration to increase heart rate variability, the best way to do that would be to extend the expiration and to eventually arrive at a deep, slow breathing pattern of about 6 breaths per minute, which is called the resonant frequency. And why is it called the resonant frequency? Because then breathing rhythms become in resonant frequency with the baroreflex. And so, when you manipulate breathing, then it would be much better to change the inhalation-exhalation ratio at a breathing frequency of about 6 breaths per minute. That would be actually my advice, and not just focus on your breath, actually. And we know that slow, deep breathing enhances heart rate variability and baroreflex sensitivity. It improves physical health. It is also likely to improve mental health, although that is much less investigated. But a very interesting finding that I want to show you as to conclude with is an Italian investigator, Luciano Bernardi, has found that recitation of a Catholic rosary or yoga mantras implicitly induce exactly a 6 times per minute breathing, and it is associated with enhanced heart rate variability and increased baroreflex sensitivity. So here it seems that ancient religious systems have invented some or have discovered some wisdom that physiologists now seem to discover as well. So the bottom line of my talk is maybe it's very good to pray for your health because it really helps. So I would like to thank you for your attention. This is the group, health psychology group, some years ago when I was still chairing the group. And I would like to thank you for your attention, and I'm now open for your questions. It seems that I just stayed almost within an hour.
Okay, thank you very much for very interesting talk. I first introduced the question that I received through the chat. The first question is, do you suggest that gradual exposure to breathlessness to asthma patient may decrease their chance to get asthma attack?
This is a very good question. And actually, nobody investigated this. And we have discussed that within the group very regularly. And we know that repeated breathlessness actually decreases, leads to some kind of habituation. One of my PhD students did a PhD on the effects of repeated breathlessness inductions. And most of the time, we found an habituation of the breathlessness sensation. It only led to sensitization in patients who were highly anxious and who had clinical levels of anxiety. In those conditions, we saw that breathlessness actually increased or sensitized across repeated trials. So this suggests, as a response to this question, my suggestion would be that in most asthma patients, I think repeated breathlessness actually leads to some kind of habituation. And this is probably causing also a lot of treatment treatment adherence problems, because a lot of the patients do not really respond anymore to their breathlessness. But when you deal with high anxious patients, they might over time, across repeated breathlessness experiences, develop also panic and anxiety. And this will further contribute then probably to or complicate the problem. So my suggestion would be a definite yes, repeated exposure, but then under controlled conditions, in order to prevent sensitization in high anxious participants. My hunch would be that it would lead to further improvement of difficult to treat asthma patients.
There is another question. There were several reports concerning weak diaphragm muscle activity following COVID-19, and there are reports concerning the positive effects of inspiratory muscle trainers, IMT, for COVID and other problems. What is your stand regarding IMT? IMT is
Yes,
for inspiratory muscle training.
yeah. I'm not sure what my answer will be. As I told you, I'm not a clinical person, and I have not been involved in treatment programs for COVID patients. What I do know is that, especially the ones who have been hospitalized and who have had severe COVID, I know from my colleagues, physical therapists, that they benefit a lot from respiratory muscle training, including diaphragmatic training. My response would tends to be to consider it really relevant and important, but I don't have personal experience and I don't have actual data on that.
So no other questions. So I would like to thank you very much for your talk. It was very informative and inspiring. I would add some comments, but I'm not sure whether it's the right place to discuss it. And I refer to especially the difference between a classical conditioning paradigm and the active inference model.
Oh yeah.
Which you implied.
Yeah. Actually, yeah. Actually, I avoided a bit going into the predictive coding model because given the time and the emphasis that was suggested to include at least also some comments on COVID, I sort of avoided going into too much detail. But obviously, my core business for many years has been symptom perception, and the paper I just referred to describes actually a new model that relies heavily on this predictive coding. And we are currently working also much more on completing it with an active inference component. So this would indeed lead to another interesting discussion. Yes, I apologize that I did not go into detail about this, but if people in the audience have more questions, feel free to send me a mail, and it's always easy to set up, let's say, a Zoom session to discuss some things on a more freely basis. So indeed, there is much more to say, but maybe the dialogue doesn't stop here.
אני יותר משמח.